how I treat nodular lymphocyte predominant Hodgkin lymphoma. We are welcoming to Dr. Graham Collins. Dr. Graham Collins, he is a consultant hematologist in the lymphoma lead clinician at the Oxford Cancer and Hematology Center and NIHR Bristol Biomarker Research Senior Research Fellow at the University of Oxford. He trained at medicine at Cambridge and parts of and the Royal London, and then undertook hematology training in Oxford. He completed a PhD in molecular biology of red stem blood cells, and his current research interests are in early phase trial of novel drug combinations in lymphoma, along with the development of clinically relevant biomarkers. Dr. Collins is a chair of National Hodgkin Lymphoma Study Group and T-cell lymphoma working group. He is a local PI over 30 lymphoma trials and national chief investigator of 4 investigator-initiated trials, some recruiting and some in development. He co-authored the national guidelines for relapsed refractory Hodgkin lymphoma, and he was a member of NICE guideline committee for the management of Hodgkin lymphoma. He is a course organizer for the National Lymphoma Management course and sit on the medical advisory panels of Lymphoma Action and Bloodwise. He is passionately concerned about improving outcomes of patients with lymphoma and improving their cancer journey experience. Welcome again, Dr. Graham Collins, and the talk for you now.
Thank you very much, Dr. Hakim and Dr. Alaskar. Thank you very much for this invitation to speak at this webinar. It's a real honor to be with you. I'm sorry I can't be with you face to face, but this is a good way to do it. So thank you again. Now let me start sharing my screen. Okay, so hopefully you can see my slides now. So I'm going to talk about how I treat nodular lymphocyte predominant Hodgkin lymphoma. And I was delighted to be given this title, partly because there is a Blood How I Treat Nodular Lymphocyte Predominant Hodgkin Lymphoma article recently published, which I don't really agree with. So I'm very happy to give a different perspective than the published How I Treat Blood paper. So if you haven't read that Blood paper, do look at it afterwards in the light of this talk. They're certainly not going to be identical. These are my disclosures. And this is what I'll be talking about. So we'll start off with the background and think about actually, is it Hodgkin lymphoma, nodular LP Hodgkin? Think a little bit about the natural history and in particular the causes of death. I think that's very important for us to understand when we're thinking about treatment pathways. A bit on treating early stage disease, which is the predominant stage of disease that patients present, the role of watch and wait, Rituximab, R-CHOP, and then I think to consider, do we actually need an anthracycline in the treatment of the majority of patients? I have got one or I think 2 slides on the treatment of relapsed disease. And then finally, I'll present to you my sort of pathway of how we initially treat patients at different stages of presentation. So in terms of background, it is a rare disease. You know, none of us see a lot of this condition. It represents approximately 5% of cases of Hodgkin lymphoma. And in the UK, that means an incidence of about 0.1 to 0.2 per 100,000 of the population per year. So that is not common. You know, in Oxford, we will see 3 cases a year, maybe, come through our clinic. So, you know, it's not a common disease. Compared with classical Hodgkin lymphoma, there are some differences. So it usually affects men. So it's a 3-to-1 male to female predominance. The median age at presentation is slightly greater than classical Hodgkin at 37, although it's still largely a disease of younger people. And most patients present with early stage disease, more so than you would expect with classical Hodgkin. And whereas classical Hodgkin commonly affects the mediastinum, nodular lymphocyte predominant Hodgkin lymphoma much less commonly. It still can, but it's not a common site of disease. The pathology can be quite difficult. And in the UK, we are now very reliant on doing core biopsies in our lymphoma diagnosis due to the problem of theatre space and engaging surgeons to get excision biopsies, but actually core biopsies are very difficult to get a diagnosis of nodular lymphocyte predominant, and often we do go and fully excise a lymph node in a patient where we're suspicious. As its name suggests, though, when you look at a low power H&E slide, you see nodules, atypical nodules, which are full of small lymphocytes, B cells and T cells, and mixed amongst those at higher power, such as this on the right of the screen here, you see the abnormal cells, which are different from Reed-Sternberg cells morphologically, and they also stain up differently. So whereas Reed-Sternberg cells classically lose the B cell phenotype and are CD20 negative, these LNH cells, or popcorn cells as they're sometimes called, are typically CD20 positive. They have lost quite frequently some of the B cell markers, but not usually CD20. Interestingly, there's some fairly recent work presented suggesting that a proportion of cases, particularly those that are IgD positive, actually have immunoglobulin on their surface, which is specific for antigens from Moraxella catarrhalis. And there's a suggestion that these may be initiated by infection with that agent. That hasn't translated yet into treatment with antibiotics for treatment of the disease. There are, I should say, various histological variants that are described, and some of those are associated with more advanced disease and with a higher propensity for histological transformation. And one thing I will mention, which I didn't mention earlier on, is progressive transformation of germinal centers is a benign diagnosis, which you can be made on a reactive lymphadenopathy, but it can often precede a diagnosis of nodular lymphocyte predominant Hodgkin, or indeed it can happen concurrently with nodular LP Hodgkin. So again, if we have a young patient who has lymphadenopathy and the core biopsy, or maybe even the first excision biopsy, shows progressive transformation of germinal centers, we'll have quite a low threshold of rebiopsying that patient if the lymph nodes don't shrink. And several occasions we've subsequently diagnosed nodular LP Hodgkin. So not an easy diagnosis to make. One thing I get asked quite a lot is, should we really be calling it Hodgkin lymphoma? Is it a subtype of Hodgkin? Often it has B cell markers. It looks a bit different from Hodgkin. There's some clinical factors which I've already mentioned, which make it slightly different from Hodgkin. And as I will come on to, certainly where I work, we treat it quite differently from classical Hodgkin lymphoma. Well, there was some very nice work done and presented in 2008 in the Journal of Experimental Medicine, where they microdissected LNH cells and they compared that with microdissected Reed-Sternberg cells and also some non-Hodgkin lymphoma tumoral cells. They subjected those cells to gene expression profiling and then unsupervised hierarchical clustering. And you can see that in terms of genetic geography, if I can put it like that, the cases with nodular LP Hodgkin all clustered together. That's reassuring. But then next in line were cases of diffuse large B-cell lymphoma, and in particular T-cell rich B-cell lymphoma. Closer, the next closest then, the sort of next closest cousin, if I can put it like that, is classical Hodgkin lymphoma, followed by other cases of diffuse large B, Burkitt, and follicular. Now, I find this very interesting because I often tell my trainees that we manage nodular LP Hodgkin's a bit like indolent non-Hodgkin lymphoma, and yet genetically it's quite distinct, with follicular lymphoma on the far left-hand side here and nodular LP on the far right. So it is quite far removed from indolent non-Hodgkin and much closer to T-cell rich B and indeed classical Hodgkin lymphoma. So just expressing that in a slightly different way, this is again taken from the same paper. This is a principal component analysis. And again, the space in between the dots represents the genetic space, if I can put it like that, in between the cases. So if nodular lymphocyte predominant Hodgkin is here on the far left, its nearest cousin is T-cell rich B, and quite far away in the genetic landscape is follicular lymphoma and Burkitt lymphoma. So should it be regarded as a subtype of Hodgkin lymphoma? I think probably. You know, it's quite close to classical Hodgkin lymphoma. It shares that very rich microenvironment which classical Hodgkin lymphoma is typically shares, but it is distinct in that T-cell rich B-cell lymphoma is a very close cousin. I guess you might even call it a brother of nodular LP Hodgkin, And indeed, pathologists can find the difference between nodular LP Hodgkin and T-cell rich B-cell lymphoma very difficult, and often rely on us as clinicians to say clinically how is the patient behaving as a high-grade or a low-grade disease. Now, what is the natural history of the condition? There have been several fairly large case series reported, and I picked this one because it was the most recent one I'd come across. It was actually presented at ASH in December of last year, and this is from Finland. So it's the Finnish population database, where they identified all of the cases in their cancer registry. The Nordic countries often have very good cancer registries. So here they looked between 1995 and 2016 and identified 414 patients. And that's, I'm sure you'll agree, quite a lot of nodular LP Hodgkin's patients. And they described a 5 and 10-year overall survival of 89% and 84% respectively. So very good prognosis in these patients. Progression-free survival rates were not surprisingly slightly less, but still quite good. So almost 2/3 of patients hadn't progressed by 10 years. The 10-year PFS was 64%. They also had a look to see what were the risk factors for a worse overall survival. And they identified age as a continual variable, and also the presence of histological transformation to T-cell rich B-cell lymphoma as a relatively poor prognosis. And the risk of transformation, again, that's something else that we get asked quite a lot. It's actually very variable depending on what paper you read. We actually published our Thames Valley cases some years ago, and we saw a transformation rate of 15%, which is one of the highest I've seen. Other case series out there reported 2-year transformation risk over 10 years, whereas this publication reported a 7% risk of transformation. And I think when you take the cases in aggregate, I think the true value is between 5 to 10%. That's certainly what I say to a patient when I'm first talking to them about the diagnosis. But I think it's undoubtedly true that transformation does carry a relatively poor prognosis. And in this group, the 5-year overall survival from the point of transformation was 50%. So good outcomes on the whole. But the other thing I want to draw your attention to on the progression-free survival curve here is there's no obvious plateau. So I don't think we can say with confidence that we cure these patients. And that makes it a very different disease, obviously, from classical Hodgkin lymphoma, where we do aim for cure and we achieve cure in the majority of patients. And you see very convincing plateaus developing on longer term follow-up. You don't see that with nodular LP Hodgkin. So I think it does behave a bit more like an indolent non-Hodgkin lymphoma in that respect. And when I see a new patient in clinic, I say to them that we would expect very long remissions, we would expect an excellent prognosis, but we wouldn't necessarily be curing the patient, and that late relapses do happen. Now, one thing I wanted to point out, which has shaped my approach to treatment, is the significance of splenic disease and also a little bit on extranodal disease, in particular liver and bone marrow involvement. So splenic disease was first really highlighted as a potential issue in this publication in Blood in 2014. This is from the British Columbia group, where they identified 72 cases of advanced stage nodular LP Hodgkin, so not a common presentation. Advanced stage, the vast majority had stage 3. And in fact, if you speak to some people, they will tell you stage 4 nodular LP Hodgkin's doesn't exist. You know, if it's stage 4, it is high-grade lymphoma. Now, I don't go all the way with that. I think there are genuinely some cases of stage 4 nodular LP Hodgkin's which haven't transformed, but we do need to be asking ourselves, if we do see bone or liver involvement, has it transformed, and should we be treating it as transformed disease? Anyway, that's slightly by the by. So in this case series of 72 patients, they had a 15-year cumulative risk of aggressive lymphoma of 24%. Now that's a high rate compared to what I've told you, but these were all advanced stage patients, remember, as opposed to the Finnish cohort, which was all stages. And the overall survival and time to treatment failure were similar between classical Hodgkin's and nodular LP, but the time to progression was inferior. And again, that underlines the fact that whereas we're curing classical Hodgkin lymphoma, we're probably not curing nodular LP Hodgkin's. You can see that from these graphs diverging on the left here. They also described, however, splenic involvement being associated with histological transformation. In fact, there was a 10-year cumulative risk of 29% versus around 8% if patients presented with splenic involvement. And that also translated into a worse progression-free survival. So splenic disease on a PET scan, I do worry about when I see it in particularly a patient who's presenting for the first time. Now, one issue I do want to highlight again is the causes of death in nodular LP Hodgkin's. I think it's important to understand that when we frame our treatment pathways for these patients. Now, I got this publication from JCO, published recently in 2020. This is by the German group. They have traditionally treated their nodular LP Hodgkin's in the same way as classical Hodgkin's and have included them in their studies. So HD 7 to 15, for example, all included nodular LP Hodgkin patients. And so in this analysis, they pulled those patients out. There were 471 of them in total and analyzed them separately. And again, over 2/3 were early stage, as you would expect. And they showed excellent 10-year progression-free and overall survival rates, as we've already seen. One question they asked, again, were what were the risk factors for a worse outcome? And they identified quite strikingly here that progression less than 2 years from diagnosis was associated with a highly significantly worse overall survival. And you can see that in the blue curve here. Now, that's very interesting because I'm sure many of you listening will be familiar with this concept of POD 24, or progression of disease within 24 months of diagnosis. That's now an established risk factor for most indolent non-Hodgkin lymphomas, such as follicular lymphoma, mantle cell lymphoma, and marginal zone lymphoma. POD 24 is associated with a worse overall survival in those disease subtypes. And it seems to also be the case for nodular LP Hodgkin lymphoma here. And a 10-year overall survival of under 50% is really very poor for this disease group. Other risk factors they identified is older age at presentation, perhaps not surprisingly, and also stage 4 disease. Again, as I mentioned before, you do wonder if this may actually have represented early transformation at the time. They also identified splenic disease in advanced patients associated with a worse PFS, but not necessarily overall survival. But what was the cause of death? Now, the important message here that a minority of deaths, only 23%, were due to nodular LP Hodgkin's. Just under 50% were due to a secondary malignancy. This also includes the transformed diffuse large Bs if they died of that disease, but there were also some non-lymphomatous secondary malignancies here. However, almost 1/3 of patients died of benign causes possibly related to treatment. And I think that's very important because we are seeing very good outcomes with this disease. And what this slide here is telling us is that you may be more at risk of dying of your treatment than you are of your actual underlying nodular LP Hodgkin's. So it means that we really have to not poison our patients too much when we select an initial treatment approach. And I think that's an important message for this disease, potentially more important than for some other subtypes of lymphoma that we treat. And again, just to go back to the fact that in this group, this is a German Hodgkin study group, these patients received ABVD, most of them received ABVD. However, a reasonable proportion received BCOP, and some actually, not many, but some also received escalated BCOP, which I have to say I would really never do in a patient with nodular LP Hodgkin. And many also had radiotherapy. So those were the usual treatments approaches employed in the German group. So moving on to treatment, and to give you a bit of data that backs up, in my view at least, how we've come up with our treatment pathways for these patients. Now, this was a very interesting study presented in 2019. It was also presented at the previous ASH, looking at an international retrospective study of 559 patients with early stage nodular LP Hodgkin. And the demographics around the patients are what you would expect, median age of 39 and mostly male. All these patients had stage 1 or 2 disease. That's what they were selected that's what the study was looking at. And you can see that around half of the patients, as their initial treatment, had radiotherapy alone. Just over 1/3 had combined modality therapy, so chemotherapy and radiotherapy, and a minority, so under 10%, had chemotherapy alone. And most of that chemotherapy was ABVD, some with Rituximab, some without, and R-CHOP was the second commonest chemotherapy regime used. Now, the 5-year progression-free survival rates were very good no matter what you chose. Radiotherapy alone, there was an excellent 5-year PFS of over 90%. Now, obviously, those patients who received radiotherapy would have been selected for having disease that was encompassable in a radiotherapy field. So there may have been better risk patients than those given chemotherapy alone. But remember, all of these patients were early stage. Combined modality had a similar 5-year progression-free survival. Chemotherapy alone, perhaps a little bit less good, but as I say, they may have been a less good cohort. And observation, and I'll come back to that, so watch and wait, also had a very healthy 74% 5-year progression-free survival. Another approach that's been adopted, particularly in the pediatric world, has been to completely resect a lymph node and then observe, so then watch and wait. And again, there was a very good 5-year PFS reported there of 80%. Now, this study also had central pathology review, and they did confirm that variant immunoarchitectural patterns were associated with an increased risk of transformation. And there was around 4% of second cancers in this cohort. Interestingly, only 1% in those receiving radiotherapy, but I wouldn't like to say that's a statistically significant finding. So these are the curves that they presented, and really my interpretation here is that radiotherapy alone gives really excellent outcomes in early stage patients with actually very little toxicity. I haven't presented the toxicity data. They did collect it, and all patients really had pretty minimal toxicity, no matter what they were treated with. But I think it's very difficult in retrospective studies to accurately capture toxicity data. So I'm always a little bit wary of interpreting toxicity data in these retrospective analyses. Now, I've mentioned watch and wait or observation. That's not something we generally do for classical Hodgkin lymphoma, but we certainly do it, and I'm sure you're familiar with it as an approach for indolent non-Hodgkin lymphomas. There was a study published in Blood in 2019 from Memorial Sloan Kettering looking at various treatment approaches for their group of patients. So they had 163 patients over this time period, 1974 to 2016. And they had a reasonable number of those, 23%, were treated with active surveillance or watch and wait, however you want to phrase it. They were generally the more recent patients, just to point out that important caveat, but the 5-year progression-free survival in that group was 77% versus 87% for those who received treatment. Now, that's really very good. When I'm talking to a patient with follicular lymphoma and I'm discussing watch and wait, I generally have in my mind that there's a 3-year median duration of watch and wait before the patient needs treatment. Whereas here, you've got a 5-year progression-free survival on watch and wait of over 75%. So patients are doing really well here who are being watched and waited. Now, again, these will, I'm sure, be the lower risk patients that are being selected. But even so, that's an impressive result, I think, for essentially doing nothing. Just to flag up again, 7 deaths reported in this cohort, only 1 was due to lymphoma. So just underlying that message that lymphoma deaths in nodular LP Hodgkin's, thankfully, are very rare. What about rituximab? So I've mentioned that the LNH cells, the popcorn cells, often retain CD20, and that provides a rationale for either treating with rituximab monotherapy or combining it with chemotherapy. And there was a fairly mature follow-up presented back in 2014 of a phase 2 study, only 29 patients, and that's really the biggest series we've got. And these patients were either given 4-weekly rituximab and then nothing, or 4-weekly rituximab and maintenance treatment given every 2 months. It was a mixture of previously untreated and treated patients, so it's a little bit hard to know how to interpret this data. Very high overall responses, with almost 2/3 of patients going into a complete remission, but actually the progression-free survivals reported are not brilliant. So it's a 5-year PFS here for the single agent 4-weekly infusions was 39%, whereas the weekly plus the maintenance was 58%. So it suggests high activity, but perhaps not hugely durable responses. So it's not wrong by any means to use rituximab monotherapy, but I just think you have to be aware that the duration of the remissions achieved is probably not going to be very long. Excellent 5-year overall survivals, though, as you would expect with this condition. You can always give the patient something else when they relapse. Now, I think, you hear the word Hodgkin lymphoma and most of us think ABVD, and ABVD has traditionally been the most popular chemotherapy regime for these patients. But what about alternatives to ABVD? Well, a number of American centers generally treat with R-CHOP for nodular LP Hodgkin's, particularly the more advanced patients. And again, this is retrospective data. Pretty much all of the data we have in nodular LP Hodgkin's is retrospective. Looking at patients again from quite a long sort of treatment, a long date range. They reported 59 patients here, 29 of whom had R-CHOP, a mixture of stages, but mainly stage 3 or stage 4. And the 5 and 10-year progression-free survivals here were very good, so 89% and 59%. And again, they identified splenic disease as being associated with an inferior progression-free survival, but not overall survival. So this suggests that R-CHOP is active and in most cases induces a pretty durable remission and could be used as an alternative to ABVD. We're all, I'm sure, familiar with ABVD. The German Hodgkin study group, I once saw a debate they did, Peter Borkman did, with Peter Johnson, who's from our UK group, and they very cleverly changed the ABVD acronym into VBAD, in other words, very bad. They don't like ABVD as a regimen, and they have a point in that B is bleomycin, which we're familiar with the fact that that can cause pneumonitis in a proportion of patients. And of course, the A is doxorubicin or adriamycin, which has a degree of cardiotoxicity. So do we need to use these agents, which we know are associated with various late effects? So the question is that I'd like to address in this slide is, do we need an anthracycline? Now, this is data from the pediatric group who, when they give their patients chemotherapy, generally use CVP. Now, I use CVP for follicular lymphoma combined with rituximab, but there the V is vincristine. However, in this group, the V is vinblastine. So it's a slightly different CVP than perhaps most of us are used to. They didn't use rituximab here either. It was purely CVP. And there were 55 patients in this cohort, all under 18 from UK and France. They all had stage 1 or 2 disease. And the way they treated these patients is the lymph node was if the lymph node was fully excised, they would simply observe. They wouldn't give radiotherapy or anything. But if it wasn't fully excised, that's when they would go in with the CVP. And I've listed the doses down here. You can see the cyclophosphamide as well is a little bit of a lower dose than perhaps we're used to using. And they reported an 80% complete remission or CRU rate. They didn't use PET scans in this of 80%. And really confirming in this small group of patients that an anthracycline and bleomycin free regime is active in early stage disease. So it was early stage, it was only a small number of patients, but again, it raises this issue. Do we really need to use an anthracycline and bleomycin for these patients? Okay, and then just 2 slides really on relapse before I'll present what my approach is to newly diagnosed nodular LP Hodgkin in the round. Now, it's a tricky thing to present on, really, relapsed nodular LP Hodgkin's, because there is very, very little data in the literature of how to optimally treat these patients. Now, I've taken this slide from the Blood publication of how I treat nodular LP, because I think this approach is as good as any, to be honest. And they've split it into early relapse or late relapse. And I think that's a very reasonable way to split it. As I've mentioned, a relapse within 2 years of initial diagnosis is associated with a significantly worse overall survival. So for the late relapses, the lower risk patients, there are a number of options. If a patient hasn't had radiotherapy and they're presenting with early stage relapse, I think radiotherapy is an excellent option depending on where it is and what the late effects risk is. Rituximab alone is a reasonable option with the caveat I've mentioned before, that the duration of the remission may be not as long as hoped. Conventional chemotherapy, adding in rituximab, so if they haven't had CVP before, or R-CHOP, or ABVD, or AVD, all these options are perfectly reasonable, or indeed active surveillance. And I will mention a patient who's under my care who first developed nodular LP Hodgkin when she was 16. She's now 35. She was actually treated at a different center quite aggressively, as you would for somebody with classical Hodgkin lymphoma. So she had 2 rounds of treatment. She had short relapses in between each one. So she was relatively high risk. But she then came under our care, and my colleague, who's now retired, said, actually, you've had a lot of treatment, but he wasn't actually sure she needed that treatment in the first place. So we've watched and waited with her now for about 10 years, and she's got stage 3 palpable disease, which has never really grown. So she's delighted. She's very well, asymptomatic apart from the palpable lumps. And we very much plan to keep watching and waiting her, even though she's relapsed twice before. So watch and wait is a reasonable option at relapse. For early relapses, the higher risk patients, I think it is reasonable to go in with a much more aggressive approach and to use higher doses of chemotherapy, even with an autologous stem cell transplant potentially. And actually, I have a patient who's under me now, a young man who presented when he was 20. He actually had ABVD. He had stage 3 disease. And after 6 courses of ABVD, he actually had persistent disease on a PET scan, which we observed, and it gradually progressed. But then he kept not attending for appointments. He was very poor at engaging with the health system. And he presented recently, just the other week, after 5 years of not being under us. He's now really quite unwell. Clearly with stage 4 disease, and I'm fully intending, no matter what the biopsy shows, whether it's transformed disease or not, to go with a salvage chemotherapy approach and an autologous stem cell transplant. There are obviously alternative options there for patients who aren't fit enough or who are perhaps not as high risk as the patient I've mentioned to you. Now, what is the role of autografting? You know, it's not a common indication for an autograft, nodular LP Hodgkin. So just to present the best data that I've seen, this is from the European Bone Marrow Transplant Registry, presenting 60 patients over 10 years. They did not have biopsy proven transformed LP Hodgkin, but of course it's very difficult, isn't it? If you've got somebody with a lymph node and liver and bone marrow disease, you might biopsy the lymph node and it might be nodular LP Hodgkin, but they may have transformed disease elsewhere that you haven't biopsied. So it's very hard to exclude nodular LP Hodgkins, transformed LP Hodgkins rather, with confidence. These patients had a median diagnosis to autograft time of 21 months. In other words, they will have relapsed very quickly after their initial treatment. So these, I think, are high-risk patients, and they had a median prior lines of 2, and most patients had a beam conditioning, which is certainly the conditioning which is still our go-to regime in Oxford. And they were all in some sort of response, CR or PR, at the time of transplant. And there was a 5-year progression-free survival of 66%, which, as I say, for a high-risk cohort isn't too bad, and a 5-year overall survival of 87%. Comparing that with the German data with a 5-year overall survival of 47%, this is favourable, but obviously this is a select patient group. All of them are fit enough and well enough for an autograft, and all of them are in remission at the time of transplant. So it's hard to say autografting has clearly benefited these patients, but it's certainly associated with reasonable outcomes in what on the surface looked like a high-risk group. So when we think about our first line treatment options, I think these are the factors to consider. I hope I've persuaded you on some of them. Observation is reasonable for some. Radiotherapy is very effective for localized disease. Rituximab alone is active, but perhaps not durable. So you may want to combine that with other agents for durability. ABVD certainly is a reasonable option. I wouldn't criticize somebody for giving it, but it does have bleomycin and anthracycline. And do we have to use that for every patient? There was a very interesting poster, as an aside, presented at ASH this last year, showing that in patients with classical Hodgkin lymphoma, after 10 years, there's a 2% baseline risk of cardiac failure. That's in the general population, and that rises to over 4% in patients who have had ABVD alone. So 4% still isn't high, but you've more than doubled their risk of heart failure by using an anthracycline, no radiotherapy in that group. Splenic and extranodal disease may imply a higher risk of poor outcomes and indeed earlier transformation. That's important to bear in mind. And the other important factor is that the risk of dying of nodular LP Hodgkins is low, so it's important to minimize treatment toxicity. So how do you sort of put that together into treatment pathways? Well, this is our approach that we've adopted in the Thames Valley. So if a patient presents to us with stage 1 disease that's been completely excised as part of the diagnostic process, we will simply observe them. We won't give radiotherapy, we'll just watch and wait. If it's a stage 1 patient where the lymphoma has been incompletely excised, or perhaps they've just had a core biopsy, depending on where the lymphoma is, we would either go, and factors intrinsic to the patient, we would either go with radiotherapy to that area or simply observe it. So, you know, if we have a 50-year-old with left-sided neck disease, that's very low risk for radiotherapy. So we would almost certainly advise radiotherapy. Whereas if we have a 20-year-old woman with axillary disease, we may be a bit more cautious going for radiotherapy because of the amount of breast tissue involved in that radiotherapy field in a young woman, increasing the risk of breast cancer. So these sorts of discussions are had at our multidisciplinary team meetings and indeed with the patient to get their view. So those are the factors we would consider deciding between those approaches. Stage 2 disease, similarly, we would either observe or give radiotherapy depending on the field involved and patient factors. And if the patient's symptomatic and radiotherapy isn't considered suitable, then we are actually using RCVP, which is the traditional RCVP with vincristine, just because we're simply used to using that as adult treating clinicians. So we're avoiding an anthracycline and bleomycin, albeit I have to admit there is not huge amounts of data reporting on that approach as yet. For stage 3 disease, depending on the symptoms, we may well watch and wait in somebody who's asymptomatic and with low bulk. Whereas we may, if they're well, go, but perhaps symptomatic disease or disease we feel we need to treat, we may go with RCVP again initially. If there's splenic disease or perhaps a variant histology, which we're worried might predict earlier transformation or a worse outcome, we would have a low threshold of recommending R-CHOP. And for pretty much all stage 4 disease, or certainly confirmed transformed disease, we would go with R-CHOP as well. But even if we've only shown nodular LP Hodgkin's on a biopsy, but the patient has, say, liver involvement and splenic involvement, I personally would be very worried that there may be impending transformation that we just haven't picked up. And I would probably be going with an R-CHOP approach in that patient. So thank you very much for listening. I'd like to finish just with an acknowledgement slide. So these people on this slide are the UK Hodgkin's study group. And it's I chair that group and I'm chairing it for the next few years. And it's a real honour and privilege to be working with this really committed bunch of people. There are some people here who've done some work on nodular LP Hodgkin's. This is Anna Shankar, who did the work with the CVP that I mentioned, and Pam Mackay, who I actually can't see here. I think it's probably being obscured by my pointer, but she's also done some work with adult cases reporting on some retrospective series. So, and we're hopefully going to get involved with an international project led from the US, trying to really increase the number of cases in retrospective studies that are to be reported. And thank you very much for listening, and I'll be delighted to take any questions.
Well, thank you very much, Dr. Collins, for the very well comprehensive presentation. And we will start to move to receiving questions from Dr. Amir Alim. He is having, if you choose the observation approach in a patient, what is your surveillance plan? How often do PET scan, keeping in mind young patient and exposure to radiation?
Yeah, no, it's a very good question. So we generally don't do routine scans in a patient on watch and wait, whether that's for nodular LP Hodgkin's or for follicular lymphoma or marginal zone lymphoma. We go clinically. So generally I would see a patient every 4 months for the first year and every 6 months for the second year. And we may keep going with 6-monthly review, or sometimes go annually if they're very, very stable. And we just do 3 things at that clinic appointment. We ask the patient how they are, we examine them, and we do blood tests. Now, we have a very low threshold for then doing a scan. So if the patient has new symptoms that are concerning, we may do a scan. But on average, that probably means we scan a patient every other year. Now, as I say, that's not routine. We do that triggered by symptoms or abnormal blood tests. But you're absolutely right that we need to be careful with the radiation dose for these patients. The most important thing I find, though, is we have excellent specialist nurses, and they are contactable, 9 to 5, Monday to Friday, and we make sure the patient has their contact number so that if they notice a new lump or any developing symptoms in between clinic appointments, they have a contact number to ring straight away, and that's very helpful as a safety net.
Thank you. Thank you very much, Dr. Collins. I think we don't have any more questions. I have a case which was presented 2 years back or 2 years ago. She was 28 years old lady with stage 2. She was diagnosed with stage 2 nodular lymphocyte Hodgkin lymphoma with 2 cervical lymph nodes, one excised and the other one, she was stage A, she was asymptomatic, and received at that time 4 cycles of RAVD, which was Rituximab was given monthly on and off. And she was PET post chemo, it was negative. Around 4 to 6 months post chemo, she returned back with new lymph node, submandibular, and it was excised, shows inflammatory process. Later, more than around another 4 months more, she presented with another lymph node, and we excised for her. It was showing nodular lymphocyte predominant, and at that time the decision was difficult, whether to give her RT versus watch and wait. And her CT was showing all lymph node was subcentimetric, but was not significant. And although she was also asymptomatic, and I think here we have 2 choices for her: radiotherapy versus chemo, followed by autologous stem cell. So I think it is relapse. I think it is not, yeah, I mean, majority of cases, they relapse. So we refer her to higher center for radiotherapy. And I think she went, at COVID, she could not able to go to the central hospital for the, to follow the chemo option there. But I think this is the usual nodular lymphocyte.
Yeah, so she was quite
as they are relapsing early.
She was quite an early relapse, wasn't she? So yeah, that does put her in the higher risk group.
Yes.
I mean, I think your plan of radiotherapy, if the problems were localized, absolutely is very reasonable. You know, as I mentioned, I do sometimes go with a higher dose chemo and autograft approach, but I normally would do that only when I'm really convinced a patient needs the treatment. So when they're very symptomatic, or when there's clear, quite rapid growth. I mentioned this patient we've been watching and waiting for 10 years with relapsed disease. She has obvious, you know, stage 3 disease. You really can feel, you know, 1.5, 2 centimeter nodes in the neck, axilla and groins, but I've been feeling those nodes for about 10 years now, and there's really been very little change despite biopsy proven nodular LP Hodgkin's, and she remains well. So I think relapse in and of itself doesn't necessarily need urgent treatment, but if it's localized relapse, I think radiotherapy is very sensible, because you can then get very long remissions from that. But if it's a symptomatic early relapse, yes, I think chemotherapy with consideration for higher dose treatment as a consolidation is also reasonable.
I have a question from Dr. Qadir Ahmed. If you use RCVP, how many cycles be given, and any role of interim PET scan?
Yeah, so I'll answer the second question first. The role of PET scanning in nodular LP Hodgkin's hasn't clearly been defined. It's much better defined in classical. I think it is useful because you do sometimes identify occult splenic, liver and bone disease, which conventional CT scans are not always good at picking up. But there's really no data at all on interim PET scanning. So I have to say I don't, you know, in classical Hodgkin's, I do an interim PET on everybody. I'm a big believer of interim PET scans, but in nodular LP Hodgkin's, I don't. I do one at baseline and I do one at the end of treatment. And how many cycles do I give? I tend to, my usual approach, if I'm going to use RCVP, is 6 cycles. I might go for less than that if a patient has relatively early stage disease and responds very quickly clinically. So if they have a palpable neck and axillary node that goes away very quickly. I sometimes do an interim CT scan. And again, if I've done a CT scan after 3 cycles, say, and it's a CR, and they had relatively early stage disease, I may just give 1 more. But usually I go on to 6 cycles. I rarely go on to 8, which was, of course, the original defined regime, but I usually stop at 6.
Another question from Dr. Al-Askar. Does treatment minimize risk of transformation?
Yeah, so that's a very interesting question. We don't know. There's really no good data on that at all. And even, you know, I mean, I shouldn't liken it too much to follicular lymphoma, because as I've shown genetically, they're fairly removed diseases. But even in the follicular lymphoma world, I think that question has remained unanswered, whether treatment reduces transformation. You know, there was a very interesting observational study where the more rituximab you had seemed to reduce the transformation rates in follicular. That's the only data really I've seen that's vaguely convincing. But no, there's just no good data in LP Hodgkin that treatment reduces transformation. So I don't factor that in to my treatment decisions.
I think we will take the last 2 questions from Dr. Ayab. Any role of checkpoint inhibitors in relapsed disease?
Yeah, that's a very interesting one. There's very little data published. I think there should be, because just as in classical Hodgkin lymphoma, there's an exuberant inflammatory infiltrate. And normally MHC class 1 is expressed on LNH cells. So that would suggest that you can then mount a CD8 T cell response in nodular LP Hodgkin. And there's also quite often quite a lot of PDL1 and PDL2 on LNH cells. So you would predict that checkpoint inhibitors may work. And I think if you've got a rare, difficult case of nodular LP Hodgkin, we don't see them very often, and you can get hold of a checkpoint inhibitor, it may be worth a go. But I've not seen any, I've only seen the occasional case report showing a good outcome. I've not even seen a case series reporting response rate. So I would put it under the experimental category, or, you know, try as a last resort category if you're really struggling, but it should do.
Last question, we will take it. If you are to set a randomized controlled trial in nodular predominant Hodgkin lymphoma, which regimen will you choose to study?
So that's a very good question. So we've discussed this in the Hodgkin study group at quite some length. It's a really difficult disease to study because the outcomes are so good. You know, so to do a trial where you're comparing progression-free survival, it's almost impossible because the numbers needed are huge, and you know, the disease is rare. So actually what we had planned to do simply was a prospective observational study. I've mentioned to you that we use RCVP quite a bit. Quite a lot of the UK uses that now, and yet you may have noticed I didn't present any data on the outcome of RCVP, particularly with vinblastine, in the literature. It doesn't really exist. So we do want to collect the data, and we'll probably be doing that retrospectively like everyone else, all the other types of study you've seen, to actually publish some data to check it is a reasonable thing that we're doing. So that's what we want to do in the Hodgkin study group. We did have designs on a prospective study with translational endpoints, but we couldn't get funding for it. But I'm afraid we just couldn't find a suitable design for a randomized study with the required patient numbers. But it is the RCVP regime we're particularly interested in looking at.
Thank you. Last question from Dr. Al-Askar. The data you showed about majority would die from treatment toxicity is needed, scary, and may emphasize on the watch and wait approach, or rituximab would do. What do you think?
Yeah, so I mean, I would point out, I don't want to overly overinterpret the data. From the German Hodgkin's group, they did that third of patients dying. It actually said from benign causes possibly related to treatment. So, you know, was it actually the treatment killing those patients? It's hard to be sure, but I think there's a concern raised in that publication that you may be more likely to die of treatment effects than of the nodular LP Hodgkin. So, you know, I don't want to overinterpret it, but it is a worry. And yes, I think we need to be cautious in giving combination chemotherapy to these patients, because as we've all seen, even the best tolerated combination chemotherapy regimes, occasionally you come to grief. I mean, I had a 31-year-old with classical Hodgkin's who I gave 6 cycles of, well, 2 cycles of ABVD to, and then 4 of AVD, as we do now as fairly standard in the UK. She got through it until the end of her 6th cycle, and then she died of febrile neutropenia. I mean, incredibly rare, thankfully, but devastating to have that happen. And it was a consequence of the treatment. Now, she needed that treatment for the classical Hodgkin's, so it was tragic, but you know, I would still give patients ABVD and AVD for classical Hodgkin's. But I just question whether we need to be using ABVD, BCOP, escalated BCOP, even our CHOP for most of our nodular LP Hodgkin's patients. And that's why I think a lighter approach such as RCVP or indeed Rituximab single agent may be better. Yeah.
Well, thank you very much, Dr. Collins, for your nice and comprehensive presentation and sharing with our series. And I would thank you and thank our sponsor, Takeda. I would thank also our audience for their participation. And we will see you soon, inshallah, in the next Saturday, in 6th of February, for the with the talk with Mahdi Hamdani, and we will talk about CAR T-cell therapy, current status, and future.
Thank you very much indeed. Thank you.
Thank you. Thank you, both of you. Excellent.
Thank you. Bye-bye.
Have a nice evening.
Thank you, Anju. Bye-bye.
Thanks.
Thank you very much.